that oath that we have taken to help our patients has absolutely been exploited by the healthcare system.
Welcome back to another episode of the podcast for doctors by doctors. I'm Dr. Michael Jerkins, joined by the one and only Dr. Ned Palmer. Ned, are you there, Ned?
I am here, Dr. Jerkins.
You're here.
What's
I'm glad
that?
you're here.
I am also glad I'm here. How are you today?
I'm good. I have a total non sequitur to start this amazing show that we have with our amazing guest, but I was actually, I don't know what you call it in your neck of the woods. In my neck of the woods, we call it rolled. Some people call it TP'd.
Oh,
But
yeah. Oh, wow. Okay. Real Devil's Night classic here.
yeah, so Devil's Night, I don't know about that, but I know that you guys in Michigan say that phrase. But
Detroit specifically, but sure. Yeah.
okay, you can have that, Detroit. But it was hasn't happened since high school, so I didn't know what was going on, and I was kind of an angry old man and cleaned it up last night.
Now, what's interesting is who are the culprits here? Do you think this was a random act?
I know who the culprits are.
Oh, okay. Do you think this was a random act of homeowner violence, or no? This was
No, what's different than when we were in high school is that there are doorbell cameras, and I have one, and
a
so
lot of them. Yeah. Okay.
so I do know who it was, and it's someone I know, and it's friendly. But it was just a blast from the past, and I hadn't had to clean up toilet paper from trees in my yard for a very long time.
I hope you didn't get egged too. I feel like that was the 1-2 punch that used to come if you were actually like quite upset with someone would egg their home.
That's next level, I feel like. That's too much. That's too much.
It's too much. And frankly, again, I'll be an angry old man here with you for a sec. Like with the price of TP and eggs anymore, like who's even got the capabilities? I mean, the level of waste there. We went from hoarding toilet paper for a whole year in 2020 to just profligately throwing it around the yard now. I guess that's progress, but it doesn't feel like it,
No, you're right. It kind of prices a lot of people out of that particular type of vandalism.
That
I'm sure
kind of
there's other
behavior.
forms that are not as expensive.
Are you comfortable naming and shaming the culprit on this podcast?
I am in general, but not on this podcast. I promise you they're listening though, and they will hear this.
So was it directed at you or your son? Because I have to imagine
No,
in high
it
school,
was
it was
me.
probably directed at you.
It was me.
Oh, so it's still directed at you 25 years later. You're still the central reason behind the rolling? Yes.
We call it rolling, like a toilet paper roll.
I could make that leap. Yeah. Okay. All right. I feel
Devil's
like,
Night seems a little aggressive. Why would you guys call it that?
Because we used to burn down the city of Detroit. Pretty well established that through the 70s and 80s and 90s, all the abandoned homes would get set on fire on the night before Halloween on October 30th. It is one of those things that when the assumed normalcy of your youth, I thought everybody did this, and it turns out that it is hyper local.
That seems like a joke.
I mean, I don't think anybody was kidding. I think a lot of people did it for insurance checks. I think a lot of people absolutely committed fraud through it while pretending to celebrate. It's the history of Devil's Night is actually its own fascinating separate podcast I'm going to start up. So this is the Devil's Night for doctors by doctors with Ned Palmer, where I'll be interviewing Michael Jerkins about his preconceived notions around Detroit cultural norms. So,
Well, let me say, I feel like it's a good segue here into our interview, which is doctors' lives are stressful in lots of ways, including having your house vandalized. But I am very excited about our guest, Dr. Graham Walker, who is someone I've been excited to kind of get to know recently because I've used his app on my phone for a very long time, MDCalc, and he is a pioneer in technology and medicine and really an advocate for doctors. There's a theme here of a lot of people we have on this show, and I am really excited to be able to pick his brain and hear more about his story.
I am as well. I don't think that a doctor we've interviewed yet or a guest that we've interviewed yet that I've used more of their end product than Dr. Walker and MDCalc. I was thinking about this a lot in the run up to this show, and I cannot imagine or point to a single thing that I don't, unless I mean, I don't know, maybe the only other one I could ever think of is like who found it Up to Date. And I don't even know if that's a known entity like Dr. Walker is.
It is I think it is an individual physician that started Up to Date, but you're right. I mean, that now it's a conglomerate. I think to MDCalc is to a degree of people uploading their own tools. But I hear what you're saying. What's interesting is we had Mark Cuban on. We use Cost Plus. I know I use it a lot. I probably use MDCalc a lot more than Cost Plus drugs. But I am excited to have him on. So let's go ahead and get to the interview with Dr. Graham Walker. Welcome, Dr. Walker, to the podcast for doctors by doctors. We're excited to have you. I'll give the audience a brief introduction of you. I know that you're well known, but for some of our audience members, they might not know some of the other work that you do. But Dr. Walker is an emergency physician, practices in San Francisco. He completed his residency training in emergency medicine at St. Luke's Roosevelt Hospital Center in Manhattan and attended medical school at the Stanford University School of Medicine. Graham is also a software developer and created MDCalc, the NNT, and OffCall, two online resources dedicated to helping physicians across the world. In his free time, Graham writes about the intersection of AI, technology, and medicine, and created the Physician's Charter for Responsible AI, a practical guide to implementing safe, accurate, and fair AI in healthcare settings. Dr. Walker, welcome to the show.
Thanks for having me. What an introduction. Thank you.
Well, you got quite a long list of accomplishments. And Ned and I were talking before you got on, and we decided that there hasn't been a guest on the podcast where we've used their work more than you and MDCalc, which we probably frequent. I know I do at least once or twice a week. I'm sure some of the folks listening probably do too.
I'll add the NNT one in because that got me through grad school. That's
amazing.
Public health. It was, that one I think is pretty incredible. So really excited to have you on here. And, when Michael says that, this is also a podcast that we've had Mark Cuban on talking about his Cost Plus pharmacy. And so to say that you're up there, at the top it's not nothing, Graham. It's pretty awesome.
That's right.
Yeah.
Well, we obviously went over some of your history in medicine. Lead us up to, or just talk to us about your journey of how you started from someone applying to get into medical school to obviously still practicing clinically, but all of the other work you do. How did you find these interests and land in the spot?
Yeah, my technology interest comes from my father, very introverted psychiatrist that we always had computers. I mean, from age 4 or 5 and floppy disks and everything. I mean, I'm 44, so I'm a elder millennial, right on the cusp there of Gen X. And so the tech all comes certainly from him and gadgets. And, I was like learning how to, get around, navigate the computer and Microsoft DOS, even before Windows 3.1. So that all certainly comes from him. And then, the medical side certainly comes from both of my parents. My dad's a psychiatrist. My mom was a psych nurse and a dental hygienist, and certainly had health as part of her career as well. And they're both, first generation healthcare people. My dad was the first, physician in our family. My mom, first person in healthcare as well in hers. And, always thought like, oh, I like this idea of medicine and being a doctor, but I don't think pre-meds really know what that is like. I don't think you maybe even know what that's like as a med student. But I always wanted to combine the idea of being able to help one individual person with helping groups of people. I mean, that was honestly the dichotomy that I struggled with to decide if I wanted to be a pre-med. I mean, that plus like doing organic chemistry at 8 in the morning in winter quarter at Northwestern in Chicago, where like my eyelids would like freeze shut. So the way I kind of satisfied that in my brain was I was a social policy major in college. So did of course all the pre-med requirements and took the MCAT, but then also had a lens of like, okay, I don't want to just help one person, but like I want to take that ability to help one person and then scale it to larger groups of people. Worked for a nonprofit around healthcare reform, single payer national health insurance for a year before medical school, and then got into medical school at Stanford, and then kind of continued to work on the policy side. In kind of community health and policy as we kind of had little focuses in med school. That was my focus, and then like just continue to build like little tech stuff in my free time. I thought all doctors were like super tech savvy like I was, because I was like, oh, I'm just the standard representation of all of us. And then I was fixing my like med school friends' printers, and like I made a little online directory for us, because this was before social media, or some of us had cell phones. Most of us, I guess, had cell phones, but not smartphones. And so we didn't, like, how do you get people's phone numbers? How do you know where people live? Like, oh, we're having a study group, or we're having a party at John's house. Where does John live? You could send email, but it was inefficient. And so I made like a little directory for us, and you could download a V card onto your, Nokia device and stuff like that. So, yeah.
It was like the Facebook for med school.
Yeah, I chose poorly. I should have developed the Facebook.com instead of going to
MDCalc's pretty cool, though. MDCalc's pretty cool.
It is. Yeah, we're used by like 2/3 of U.S. doctors every month, and I've had med students and interns and fellows take selfies with me when they find out. I mean, obviously I'm not like wearing MDCalc swag at work, and I'm not, telling people about it, but my colleagues will very kindly say, who you're working with, that's the creator of MDCalc. And then people have taken selfies with me. So I'm very flattered.
It's amazing. Can you tell us the story of that? So you walked us through kind of what you took into medical training. How did this MDCalc idea come about, and walk us through the evolution of that?
Yeah, shout out Monica Devaccaruni. I think Monica's an interventional cardiologist. I think still at Stanford now, or I think she's still in the Bay Area. But she was my chief resident, and she was asking me questions about a score. And and I think her expectation, or at the time, it was like you memorized these scores, and the scores were very simplistic. They were all like +1 point, +2 points to keep the math simple for humans, which made sense. And you either memorize them, or we had those little pocket books that fit in the deep pocket of your white coat, and they're in those little tiny little cute little 3-ring binders, and you would look at the 8-point font to find the score for Ranson's criteria, or some of the I'm blanking on the name, some of the older like chest pain and ACS, acute coronary syndrome scores. And I taught myself web design. I've been doing websites since I was probably 17 or 18, and then saw this as a niche that I could solve this problem in a better way. Why don't I just build a site that just has all these? There can't be that many. And at the time, there weren't that many. There were probably, I think maybe the original version of the site had 40 or 50. And I would just go through those little binders and find every single one and just add them. Even if I didn't know what they did, I would add them all. But obviously now there's thousands. We have I think between 800 and 900 now on MDCalc, but there's our backlog is exponentially growing, right? So that's the other challenge, is that just as research is exploding and is exponentially growing, that's the other challenge, is just keeping up with all of that as well.
Yeah, absolutely. So within the MDCalc sphere,
yeah,
was that the initial game? Was just to grab everyone that existed at the time, or were you was there any quality control or check step, or we never really liked this score? There's the human aspect of this too, right? Of especially if you're talking about the 3-ring binders, I assume you mean, what was it, probably the red book or the green book then? MGH's hospital medicine handbook.
Yeah. Mine was green. I think the first one I had.
I think mine was blue. Yeah,
blue.
Maybe that was just the year it came out or something like that.
It went through color eras. Yeah.
Yeah. There was absolutely no quality control at the time, and it was just if it made it into one of those little internal medicine handbook things, then it was clearly being used by people. So I was just okay, I'll just add all of these, and then I would ask the interns, do you know any other scores I could add? And then I would go on PubMed and look them up, and then try to download the PDF, and then I would just turn it into a calculator. So no quality control at the time. Now we have a lot of quality control, because the growth of the scores has changed a lot. And then, my co-founder, Joe, and Habush, another ER doctor, and I, we understand that we have like a moral, ethical responsibility to do it right, because we have a ton of physicians' trust. People know and use and love MDCalc, which is wonderful, but that comes with responsibility as well. That like if it gets on MDCalc, people will say, I guess maybe, oh, this is reliable, this is validated, this is safe to be using on my patients in front of me. And so we have a whole process to review every score and then build it out and test it and everything and validate it, because we're the place that people go to solve this problem.
Yeah, I mean, even before now, it's like I don't double check your math. Like if I'm even something relatively straightforward, some of these older is PORT or PERC or Curve 65 or something, which are still kind of like your +1, +2, or -1. Like I'm not checking. Like I have delegated that full authority to MDCalc just to free up some neurons, hopefully.
Well, and we have warning and then alert or error values for every field that you have to input, because we know people can fat finger stuff and have typos and stuff. Occasionally I'll have people tag me on social media and say, "Oh, you need to fix MDCalc because the glucose of my patient was like 1,500, and I think maybe our cutoff is 1,000 or something like that." And they're like, "Oh, it didn't account for this use case." And I'm like, "No, I get it, but we actually don't want to account for every use case in what is biologically possible. We want to have some wiggle room of standard deviations, because it's entirely possible that you meant to type in 1,500, not 15 or 150 instead of 1,500. And so we need to warn people and let people know, like, hey, double check that this is accurate." And, we always provide the actual calculation, how we arrived at that result, what the algebra is or what the logic is, so that people can double check it or just calculate it themselves. If you have some crazy calcium of 30, which probably is not compatible with human life,
Yeah. And then I mean unit handling as well, right? Because now with MDCalc being exposed globally, and I've seen people use it all over the world, I've used it all over the world. Even just operating in the English medical system, they use a completely different unit set and everything else. So your glucose is 1, not 150, and that's fine. But so you need to actually manage both ends then. And so from a data standpoint, so is that, I guess now from like an MDCalc standpoint, like is that a team that's kind of like continually doing that like QA QC process and continuing to refine and evaluate? What does that look like to make sure it's maintaining the quality in?
Yeah, we are frequently looking for bugs and respond to them, frequently from users and double check things. And, the errors we're seeing really are now more on the technical side, like that not that the calculator itself is wrong, but there's a problem with like the server that's running MDCalc. And if you're getting an error message, it's like actually a problem with the Amazon Web Services or our configuration or something like that. Because we keep all the logic that calculates the score or whatever very stable, and we test it on all the platforms before we release it. And then we have a whole process where if somebody says, "Oh, you should add this score," we have a whole internal team that reads the paper, reviews it, makes sure it's accurate and validated and appropriate for MDCalc, and then also that it's like actually clinically useful. During COVID, COVID just, especially in 2020, there were just hundreds of scores. Everybody was coming up with a score for everything. And, I remember there was one for like the COVID anxiety risk score. And it was like, how much of the patient's anxiety is due to anxiety about COVID? And I was like, I don't know that this is like, how clinically useful is this? That's the whole point of MDCalc is like, we're trying to solve doctors' problems. And if somebody could tell me the way that solves a problem, sure, we'll add the COVID anxiety score if it's been validated. But if it doesn't get to the level of how's this going to change your management type question, then it's like I don't know how valuable MDCalc is then.
And I see a lot of your writing and stuff online, especially as technology in the last 2 years for the non-techies in the population has evolved very quickly and become prominent in our lives, or maybe it wasn't. And there was a recent study I saw you commented on. I'd love to hear more of your thoughts, but it was in JAMA, and it was testing, I guess, how much a large language model AI tool might help us diagnostically. And there was this kind of aspect of it that hinted at a large language model by itself was actually maybe even superior to a doctor's diagnostic skills. That was one of the tweets or headlines you saw. Talk to us about that study and how would you respond when people ask that question? Is AI better at diagnosing something than a doctor?
Yeah. Shout out to my friend Jonathan Chen, who was an author at that paper. Jonathan was an intern when I was a med student at Stanford. So we've known each other for several decades, and now he's a professor at Stanford in clinical informatics. Yeah, the study's really interesting. You know, they had kind of three groups. One group was like just have the large language model, just give it a case presentation with labs and imaging and everything, and say, hey, figure out the top three diagnoses. And then there were two human groups. One human group was allowed to use the large language model to help them figure out the case. And then the third group was use whatever you would normally use. So that might be Google or UpToDate or whatever. I agree with you, Michael. The headline in the New York Times was that AI defeats doctors in diagnosis. And it was inflammatory and not a very good headline, but certainly very good clickbait, and it got a lot of discussion. So I guess maybe it was a good headline. The challenge with that was, as Jonathan has pointed out, a lot of the reason that the large language model plus human piece didn't do as well as large language model alone was that the physicians actually probably didn't really know how to use an LLM fully. That they were, they weren't just copying and pasting the case summary into the large language model like is actually quite a successful strategy. They were using it more like a search engine. So they were typing in words or phrases or poignant, pertinent details from the case, not the entire case itself. So, number one, I think just shows you that you need a lot more education and training for physicians. I think those of us that even know what the term large language model is or knows what ChatGPT is are already probably one or maybe even two standard deviations different than the rest of medicine. And then, the other piece is the other piece around, large language models defeating doctors is looking at the case presentations themselves. So these authors took the case presentations from a paper in the New England Journal from like the mid 90s. And they, again, were testing how technology, computer tools could help with diagnosis. But this was in the 90s. So we didn't have any of the technology we have at the time that we have now. And so these case presentations were like intentionally very challenging cases. It wasn't like somebody with pharyngitis or somebody with pneumonia or hyponatremia or like any of the top 100 cases that the three of us would probably see in our practices on a daily basis. The example they give was like cholesterol emboli syndrome, which is I've never seen. I asked a bunch of my friends who are interventional cardiologists, and one had seen one case in residency, but they were intentionally difficult cases. I think for those type of cases, large language models could be very helpful. Just like there were cases where, like literally the authors wrote in this New England Journal paper, like, oh, hey, we picked cases that you'd probably like curbside your buddy or your friend on, or you get a formal consult on because you have no idea what the hell is going on with this person. So in that way, I think it could be really helpful. But for common garden variety stuff, I don't know that a large language model would be helpful, and it could maybe even lead you astray because you're not going to think of the common stuff. You might defer to the large language model that says, oh, this is I can't even tuberous sclerosis or some very uncommon. It's not a lipoma. You should consider tuberous sclerosis, right, or something like that.
Yes. So it like basically maybe is overweight on zebra diagnoses if you used it that way, probably.
It may be, right? I mean, that's the other piece that I try to advocate for is we just don't even know. I think we really need rigorous studies to look at how well these things perform. And the other, I guess the last challenge I'll say is it is practicing medicine is not the same thing as reading a comprehensive case report and then trying to come up with a diagnosis. As the three of us know, and I'm sure your listeners know, you have to sometimes you have to pull the data out of people, or get to a final case presentation. You got to transform that. If the patient says it's been going on a while, you need way more detail than that. And that is the interaction that a human gets from another human. And you can imagine a large language model, if they get garbage in, they're going to kind of give garbage out too.
Yeah, I mean, that's like where I've seen a lot of people use it. I'd love to hear your opinion on AI looking at imaging or some sort of objective output that they're analyzing, as opposed to a patient interview and exam where there's a lot of subjectivity. There's two humans talking to each other and exchanging information. And there's a lot of colloquialisms and things that you have to read between the lines and understand. And, like you said, it's a headline that gets a lot of clicks, but in an actual real life clinical setting, it's difficult. But I'd be interested, do you think there's uses now that are good enough for these, analyzing radiographics, imaging, or any imaging objective data?
I think I haven't looked nearly as closely into the radiology space just because I know there are so many more radiologists and people smarter than me that know that level of nuance and detail. I think there is certainly value in not having an AI model read a study, but having an AI model prioritize studies. So you could imagine if you're a radiologist and you have 10 head CTs or 50 chest X-rays to read, you probably would want to know if a model that's pretty good at detecting intracranial hemorrhage or mass effect or pneumothorax or, batwing pulmonary edema, if the models that are trained at being pretty good at that, that's going to help your colleagues to get those reads sooner. Maybe the normals will take longer because you're not just reading studies in the order that they come in, but you're reading them in order of, reprioritizing them and re-triaging them. I think that's a potentially transformative use case right there, because you still have the human in the loop. It's still the radiologist that is interpreting the study and reading it. But the AI model can say, hey, we think there might be something here. Can you take a look at this one first?
In radiology, this is three non-radiologists talking radiology, so it's an incredibly dangerous space for us to play in right now. There's a really interesting that I'm sure I'm going to misparaphrase, but it was the gorilla in the X-ray of like, if you have an overt positive finding, like, can you hide secondary and tertiary findings? And I remember back then, that was probably 10, 15 years ago, way before we had even this language around it. There was conversation about like what comes next to prevent that kind of, like we all have in our own space. I'm poking fun at radiologists, but we all have diagnostic anchoring. We all have biases that play into it. So how do you, again, leverage this from your standpoint, from a triage standpoint, also from the ability to just stay wide open in terms of what you're thinking and cataloging? Also seems like a fascinating potential opportunity here as these develop.
It is going to be really interesting. And I don't know if it's a good or bad interesting, but it's going to be really interesting to see how this all plays out, because you're absolutely right. There's absolutely a technology bias. I mean, if we leave radiology and go back to emergency medicine, I could absolutely imagine if an AI model is telling me, "Hey, we think this person has sepsis," but to me, I'm like, they have normal vital signs. Like, what do you mean? What do you mean they have sepsis? Is this the right patient? Am I missing something? So and then you get back to how does this change my management? Like the action question. Well, what am I going to do about that? Do I listen to the AI model and order a lactate and blood cultures and start antibiotics immediately? Do I go back and just talk to the person and see, are they having infectious symptoms that I didn't pick up on? I forgot to ask them if they have a cough and because they're here for shortness of breath or something like that. Or do I ignore it and say it's a false positive? And how much will I defer to the referring AI model, and stop using my clinical gestalt? And will that happen all of a sudden, or will I get lazy, and will I be like, well, I'm just let the it says sepsis. Okay, I'm gonna start clicking buttons, and I won't delve deeper. I mean, I think those are all challenges of not just AI and like human computer interface and interaction, but just like the human condition. That's just how humans work, that like as things get easier, like you guys trust MDCalc, you're not double checking its work. I also don't double check a calculator. If it says 872 times 560 is something, I'm just trusting that. I'm not going to double check that. It's a fundamental thing of how our brains work. So it's not something you can build in ways to try to fight against it. You can build in ways that force the human to double check things, that force the human to, it's like the TSA thing where they'll sometimes like Photoshop in a gun or something like that to make sure the person's paying attention. You can build in systems to try to keep the human engaged and not let their eyes, glaze over, but it's really hard to do especially when the things are right much of the time.
I think that rightness is such an interesting shift because there have been sepsis early warning tools for, again, probably a decade or more baked right into the EHR. And those are a nuisance. I tend to see those pop up and I've already made my decision. I feel like I've already, I'm already down a path one way or the other. And I'm like, oh, cool, an orange window because they're breathing 21 times a minute and we have an arbitrary set point at 20. And it's the rightness, I think, is going to take like a level of frame shifting, right? I don't check a calculator because it's been right. And so I don't assume it's kind of drifted off into wrongness. And so I like, what is that level of where we really start to shift our level of comfort here? Like right now, I don't have any. If I see an alert in Epic, like I'm just for sepsis, I'm going, okay, cool, all right, like MD aware, like it's almost tongue in cheek. So it's like, what does it take to really start to shift that? As the LLMs have overwhelmingly demonstrated that they're righter if used correctly than our current systems.
I think it takes a level of, obviously it requires it to be highly accurate, whatever highly means, at least 80%, probably much higher than that. And then I think it also takes a level of feedback to the human. So if I ignored the sepsis warning 10 times and I got feedback that's like, hey, Graham, just checking in. Did you know that the sepsis thing, it was actually right? The times you disagreed with it, did you know it was right 9 of those times? Now, and the health systems, we don't have that ability right now to remind the human, when the alert was right or when the alert was wrong. We don't have either of those feedback loops. So I think that's an additional challenge that I think is probably going to be required, at least in a transition period. I think as we start to see more models get integrated into the EHR, we'll at least need a transition period where the humans can, it's the same idea of like, we can't go directly to black box because it'll be too untrustworthy.
I am interested just to see how we talked a little bit about generational differences, people exposed to different technology and how we view technology in healthcare. I kind of want to pull on that thread a little bit more of the maybe generational differences in how we approach being a doctor. I think it made the rounds here recently, the Wall Street Journal article describing how younger doctors view their work and the later career doctors are not approving of how the younger generation of doctors views their work. What's your take on that? Did you see that article? What was your thoughts there? And do you think there's any truth behind that?
Well, the first thing I'll say is just a nod to the mainstream media, the traditional media, whatever you call it, in their ability to, despite social media and everything, to really get people talking about an issue. I mean, we mentioned the New York Times issue, or the article, that the Wall Street Journal article that came out looking at generational differences. Certainly, I mean, multiple people have texted that article to me because they want to make sure I see it so I can like respond to it or something. It's posted on Reddit. Like it certainly, those outlets certainly have a really powerful ability to shape the conversation, and start the conversation as well. I do think there are generational differences, and being a elder millennial, I feel both sides of it. I'd be curious to know if like other generations feel both sides of it, or if it's like some millennial thing that like I'm in the middle of these two opposing teams or something. The response from the journal article, the big takeaways I saw that were common themes from physicians were, number one, kind of a reductive boomer, a derogatory boomer take that the boomers sold out the younger physicians by selling their practices to private equity, and not giving younger physicians a chance to have as much autonomy and control of their practices like older physicians did. And then the also kind of I think kind of depressing, or in my view kind of sad version where if medicine is just a commercial capitalist pursuit, just like everything else in the United States is, where does that leave us? And that's what personally worries me a lot, is you really need your doctor to care. And I don't know if there's a better way to say it than like care, or be curious, or be interested on a level that's not just about like clock in, clock out, but like if you see somebody with a weird rash or a weird constellation of symptoms, you need them to be like, I need to figure this out. Or, oh, this doesn't look right. There's something wrong with this. As opposed to just saying, oh, I don't know what that is, and just giving up and, I guess I'll just refer you to somebody else. Like you need somebody to like own it, or be interested or care about this, about you or your disease, or whatever. And if all medicine is I clock in at, I'm working tomorrow, I clock in at 6 and I sign out at between 3 and 4, and it's not my problem anymore. I think that should really worry patients. It should worry our profession, that's what it's becoming. But it's also a response to how healthcare has the incentives, right? I mean, if the incentives were different, I don't think we would be at that point either. I don't know that Gen Z would think of this as just another job that they have and not as a calling. I think it's the incentives and the system that then have molded those views to become more popular and more prevalent.
Yeah, I mean, you went with the clinical presentation of this, but I thought a lot about it, and I'm not an ER doc, but I'm curious yours. Like, ER docs very frequently have control over patient civil liberties, right? You have to make judgments depending on whether somebody is safe, they're competent, they have capacity, whether or not you're incarcerated. Like, don't you want that person like to have that added, I don't know, that oomph, that extra drive, however you want to define it? We have given this group of people authority that we give to very few members in society, especially in the United States. Maybe frankly, even like the police often come in and defer on a medical question to you or to somebody like one of your colleagues in the ER.
Yeah, it worries me. It definitely keeps me up at night. Sometimes you need to go have you need to be a doctor. You need to go in and look somebody in the eyes and say, hey, I think you're making a really bad decision. And you have to pass judgment. it's much easier to just work your shift and, your potassium is 6 and you're in renal failure and you say you don't want to be admitted. Okay.
Yeah.
Next patient.
Yeah.
Click discharge, be done. I remember, this goes back to having good attendings and teaching me these lessons. I remember Tommy Wong, one of my attendings. There was some guy, I will never forget this. There was a guy who had a stroke. And this was like he'd had a stroke a few days ago, and he came in. He couldn't walk. He was hemiparetic on one side, and me as probably like an intern, very, very kind of both overwhelmed as an intern and probably some libertarian streak. Oh well, he says he wants to go home. Okay, great. One less patient for me to deal with. And Tommy, I remember Tommy said, Graham, he can't go home. You have to tell him he has to stay. And, it's that, Ned, you brought it up. It's that fine line of like, I have a lot of power and I need to do the right thing. And so sometimes you need to wield that power responsibly. Sometimes you do need to tell people like, hey, it's a free country. You can go home if you want. And sometimes you need to have like a really serious sit down conversation and just look them in the eye, or sometimes look at their family members in the eye as well and say, I'm really worried you're going to die if you go home. And it's much easier to have people that don't, that doesn't even, and that's the calling versus the job piece, right? When it's a calling, you tell people things that they maybe don't want to hear. You're going to get, maybe you're going to get a worse evaluation on your Press-Ganey score. Maybe somebody's going to yell at you, or you get an email from your boss or something that said, "Why, God, you really upset this person, that you did a bad job." Versus a job is like, I'm not even going to have that conversation because they've made up their mind. It's, who am I? I don't know. I don't know them. I don't know their lives, especially as an ER doctor. I don't know anything about my patients. Who am I to say that they're making a bad decision? But you need to at least, I was taught that you need to like have the hard conversation sometimes, and make people upset. And then if they still choose, and make sure they're informed, if they still choose to make that decision, again, free country, but you need to at least do the work of having the conversation.
I agree. I will gently stir the pot here.
Yeah.
Sometimes I do. I mean, I think the job and calling, it's an oversimplification, right? For conversational uses, right? It's a spectrum. It totally makes sense on the job versus calling clinically. I think where people are pushing back, and maybe a thread in that article that we mentioned generationally, and that's happened and people are reacting, like you said, is the non-clinical risks of it being a calling of, hey, we're having a committee meeting on some random thing that probably no one will be affected by, but because you care and you're a doctor and we expect the most out of you, you're going to show up for an unpaid hourly meeting once a month. And then, 5 years in, you look back and how many non-clinical duties have you accepted because someone made you feel guilty because it's a calling. We need you to do this. If you don't do this, then no one will. That are kind of outside that direct patient doctor interactions that I think a lot of people are starting to push back on.
Michael, I could not agree more. And I will stir the pot with you as well. I will help you stir. We'll stir the pot together. I could not agree more. And, we talked about incentives. It is that, as medicine has become more transactional and more, more challenging as you're asked to see more patients with fewer resources. And not only that, but also the ones you see are way more complex. I fully agree. I pulled up this article because I literally link this article at least once a month or something like that when this conversation comes up. And it's from Dr. Danielle Offrey. Danielle's a fantastic writer in New York, and just the headline from the New York Times.
She was our last guest, Graham.
Oh, amazing.
So
we'll
be immediately beating you out the door here. So I'm really excited to hear what she had to say. She's wonderful.
Shout out, Daniel.
Yeah, shout out, Daniel.
This article is incredible. It's from the opinion piece, and it's pre-COVID too. I mean, so just imagine, this was from 2019. The headline is, "The business of healthcare depends on exploiting doctors and nurses." And then the subtitle, one resource seems infinite and free, the professionalism of caregivers. And I could not agree more. There's not a single word I would change in her opinion piece. And that is absolutely true. And you're totally right, Michael. That oath that we have taken to help our patients has absolutely been exploited by the healthcare system. On my podcast, we interviewed Eric Bricker, who's also a fantastic guest, and Eric said, I have been in the room and I have talked to healthcare administrators who have used that against doctors. We'll just tell the doctors that the patient's blah 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 is going to happen if they don't do that. And it's a great motivator because they know it's our weakness that we do things because we took this oath that says that above all else, the patient's, problems matter more than our own. And it has unfortunately been abused. And that's the other trend that has absolutely driven this calling versus job thing to the surface is, hey, we're doing this with a societal contract that it's not going to be abused. That we're going to work extra hours and we're going to stay late and we're going to get work past the end of our shift and not get paid for it because the system is going to not make it too overwhelming, and that we won't stay late every day, but the times that we do, we will, because it's the right thing to do. But yeah, it's been abused.
Do you notice a trend in trainees, like the residents you trained with viewed their clinical work different than the trainees now?
It's a good question. I work with our own residents at my hospital. We also have visiting residents from UCSF who are ER residents. I think there's the same level of dedication from the residents, for sure. I think the residents, and I think part of this was COVID. I think the residents don't feel they don't feel as that they're as allowed to be as hands-on or own things as much. And I think part of that is probably COVID. The residents now were in med school during COVID. And so I think that probably impacted. I mean, at the time, I remember, we have medical students that work with us as well. And I think in 2020, I want to say that the med students were just told oh, you can't
go home. Yeah.
for your own safety, go home. Don't see patients in person. And I think, that translated over for residents too. Like at least early in COVID, I think we had said there was some agreement that okay, only if it's like a COVID rule out or maybe COVID or definitely COVID, only attending should see those people because the fewest number of people should be exposed to patients as possible. And I get that makes sense too, but especially when we were seeing what was happening in New York. But yeah, there are consequences to every choice and every policy too.
Yeah, makes sense. Can you, and we talked about it at the top, but off call, this seems like also a response to the issues we're facing as doctors. Would love to hear more about what it is, how it benefits doctors, and maybe the story behind it.
Yeah. So Off Call is a platform that we'll be launching in hopefully 2 weeks. Knock on some wood here, but we're getting very close to launching. I co-founded it along with my co-founder Jake Horowitz, and obviously I'm an ER doctor. Jake's wife is an ER nurse. That's how we met through emergency medicine circles. And the idea is that physicians have lost some of this leverage and power and control over their jobs and their careers and their practice of medicine and how they practice. And it is that loss of autonomy and control and leverage that has made many physicians leave medicine. Many physicians reduce the amount of time they're practicing. And part of that is lack of knowledge around their pay, both how they're paid, why they're paid, what they're paid, and is what they're making a fair number. I think we've we've gone from 20% employed to 80% of us employed in just a decade. I mean, not only did we not get training about how to like run a private practice in med school or residency, but now we didn't get training on how to be an employee and what's a reasonable expectation for the employer to do to support you as an employee. And so we want to have the ability to give people some transparency, not just the numbers of dollars they bring in or the number of RVUs they bring in, but how is their pay structured? How many patients do you see per day? How often are you on call? Do you supervise non-physician practitioners? All of that information that really is the piece that can really make a job great or really make a job terrible. And then we want to bring in some financial information for physicians, because I think we're all very anxious and worried that we're not doing our finances right, because we know we're like 10 or 15 years behind everybody else, and so we don't want to screw it up. But we also know we're like have a big target on our backs from some people that want to, sell us
Questionable instruments. Yeah.
insurance products and stuff.
Yeah.
And then, the next phase that we will grow with Off Call is some help supporting doctors who want to look at side jobs, who are thinking about leaving medicine or trying something new. Help match them with some side jobs, and we've talked to some physicians who've made that transition as well on our podcast. And then find some community as well. I think the physician lounge is gone. I think journal clubs we used to have a journal club in my group, and we're not even a particular academic group, but just that sense of community and connection, and like, hey, are you using this new drug? Or, hey, how are you handling this type of patient? I think a lot of that has kind of fallen by the wayside. And so I'd love to have a place for physicians to connect about clinical stuff, but like also non-clinical stuff too. I think physicians tend to trust each other about stuff more than non-physicians, even if it's maybe not the smartest choice. Like, hey, what kind of car do you guys like? I see people ask other physicians that a lot of the time. And it's like, oh, I might ask a car expert, but no, we tend to trust each other. We tend to trust each other a lot.
I think the worst financial advice I've ever heard has always been by other physicians. Like even people who like prey on doctors like still don't recommend things as bad as I've heard around certain areas of, this crypto thing I got into 6 months late, so I'm going to try to drag you in. So there's absolutely an element of that, and I'm really excited for it. So I signed up for Off Call, and I added my last contract's information to it. So I'm trying to do my best to populate your data set there, doing everything we can. I think what I'm really excited about for Off Call is to tie this to what we were talking about, before, and you raised the thing that we've talked about a lot of how many doctors are W-2 employed now. And what does that mean about whether it is just a job, right? Like what functionally does that mean, that massive swing, the pendulum swing we've seen over the last decade, like you mentioned? But then also, what does it mean to negotiate a contract, to sit across the table from groups of people that know and will kind of prey on your idealism in some ways? The example I use all the time is Michael and I are med peds. I was in negotiating a pediatrics contract. W-2, just very, very normal W-2 pediatrics contract. And it was said explicitly that if you take more salary, what will happen to the children? And it was like, so it's a zero-sum game, and if you pay me, there's no ceftriaxone? Like, what is that? Like, but the group, like, the group bit, we're part of a group going through this negotiation. So, oh my God, like, guys, we need to like really rethink this. We're like there's no like stopping point, right, of that level of like manipulative tactic and things like that. And so, I mean, I'd love to hear because like I said, I added my information Off Call, but do you see it kind of tangibly helping physicians through that process, like really giving them the data set to be a better, like, how would I be better positioned as a pediatrician? Notoriously terrible negotiators, pediatricians. So.
Yeah, it is certainly. I mean, I've told Jake this. It is a very doctory pitch to try to help ourselves and help healthcare. Like it's like, oh, let's give them more data. But I think it will resonate because that is how we view the world. That we need data to make decisions, and so if we can give people data, now it's it's necessary but not sufficient, Ned, just like in like your genetics class. Um, I think it's necessary to have that information. And then the other piece that we want to bring in as well is contract review, contract negotiation offerings that can help as well. Because you're absolutely right. It's not enough to just give people information. You need to then help them make it actionable. So here's the ways that you could negotiate this. Oh, they don't want to give you more pay. Okay, well, how about what if they, what if you negotiate that you have more education days or more vacation days, or you have a couple hours a week of administrative time to catch up on your charts, right? There are other ways to negotiate than just the dollars and cents of it. But you're totally right. We do have this weakness of like, well, what about the children?
And the other thing that happens too is you sometimes end up negotiating against your old program director
Yes.
for a job, which is super awkward, and no one wants
Sure.
to push the envelope. It's their old
That's a
boss.
great point.
So like actually, funny you mentioned that. I think the data is so important, but it's nice to have that expert to kind of translate and also know how to rewrite a line in a contract or know how to negotiate against that person you might know it's kind of awkward, or frankly, you just don't know how to negotiate. So Panacea Legal now exists to do that.
Oh, that's great. Congratulations, guys.
So Panacea Legal helps doctors. Thank you. Yeah, Panacea Legal helps doctors with the. We can, Panacea Legal can look at your contract. That's actually a group that not only has experience helping doctors, but also work for employers too. So they kind of know the tips and tricks that will happen on the other side of the table. And then also they help negotiate too. We have folks who say, hey, that exact same scenario I just describing. I got this information from off call from somewhere. I don't really know how to ask for more because I've never done this. And I actually know the person trying to hire me and I think they're going to hate me. So can you help us?
And it's awkward.
And it's awkward. Can you help us do that?
It's absolutely a skill set, right? It's not something that we know, and it's something that you can get better with over time. And I think that's the way we have to frame it, is like, you also weren't good at intubating or doing central lines or reducing shoulders when you first started, but it's a skill set. It's a growth mindset skill set too.
It's a growth mindset skill set, and you can learn it, or you can call a consultant. Like I'm probably not going to do a shoulder as an internist.
Yeah, if you can't get the shoulder in, I'm going to call ortho.
Call it ortho. Yes, exactly. So,
well, Graham, I know we are running up probably overtime. Sorry. Appreciate all you've done for medicine and the work you've done on behalf of doctors. Thanks for joining us. I do have one last question we ask all of our guests, and the question is, what is one thing that you've recently changed your mind about? We get tons of information and tons of data every single day. We consume lots of media. Does it just reinforce our previous thoughts and behaviors, or does it actually lead to change? And so curious for you, what is one thing you've maybe changed your mind on recently?
I will say, this might be just like my middle age or something like that, but I will say that I used to think that like there were direct cause and effects from things, like where if I did this other thing is definitely going to happen. And I feel way less sure about the world now that like, oh, if we do this, it's like, well, you would think if you, I don't know, raise the price of bread, then people are going to eat less bread. But now I'm like, well, maybe they'll eat more bread and they'll just eat less of other things. Like I just feel way less sure of where I think the world is going to go. And, in some ways that's scary, but it's also like I'm more open to possibility and, change than I was.
Yeah, makes sense. And it's been a crazy, tumultuous last 5 years, especially. So some of the previous structures that we would have thought would have led to predictable outcomes did not. So that makes total sense, good and bad to that. But Dr. Walker, thanks for your time. Thanks for joining us on the show. And especially thank you for all you do for doctors.
Thank you. Ned, great to meet you. Michael, great to see you again.
Ned, that was awesome to get to talk with Graham. Lots of interesting takes there. Interested to see if you have any salient points that you're going to take away from that combo.
absolutely. I mean, before we get to the actual salient points, like I really appreciate that we get to talk to like medical celebrities. Like I feel like Graham Walker could probably walk around the world and not be accosted. But I love hearing that like within our incredibly specific narrow group of people, like MDCalc cut such a broad impact to the field of healthcare. The people are stopping and taking selfies with him when he's in the ER and actively at work. I really appreciated that. I think that speaks a lot about our community and how we value the output of some of these incredible things that have just been developed organically. They're incredible. I love that little anecdote that he gave.
Yeah, that is hilarious. That is a life goal, I think, for a lot of doctors to walk around, and then another doctor's like, "Hey, I want to get a selfie with you because you did such a good thing that really has made my life better." But I maybe that's just other people. But I also think it's interesting this conversation with the whole older generation, younger generation of doctors. How do we view work? And I think I didn't say this on that, but I think that some of these themes are repetitive. Like over time, the older generation, no matter what industry it is, tends to think the younger generation doesn't work as hard, or there's some deficiency, and then that younger generation grows up and says the same thing about the next, and then history repeats itself. Not saying there's no truth to it to a degree, but it is something that you just continue to see over and over throughout time. I like that the way he framed it of what the newer generation of doctors, how they view medicine as a reaction to how healthcare has changed over time. Not only is it, different as far as the expectations doctors have, the paperwork, the way independent practice is totally flipped. We're almost all employed, but also the debt. Like that was something we didn't talk about with Graham, but that changes a lot of how people view their job or their calling is when they have $300,000 or $400,000 of student loans they have to pay off.
Similarly, the incentivization structure. We talked about it a little bit, almost tongue in cheek, about, my Press Ganey scores may suffer for doing X, Y, and Z. A lot of physician specific metrics really aren't targeted towards quality based outcomes. So you could do the right thing, you could do the hard thing, you could do the calling, but we're not incentivized on a time based model. We're incentivized typically on an intervention based model or a throughput based model, or in some ways, like a shortening of length of stay. The example that he uses about the emergency room, taking the extra time to coach a family through something, that's way worse for him across probably multiple different metrics that he's graded upon. It extends his length of stay. There's not a procedure there. It turns into an admission. All of these things are probably net worse for him depending on the financial incentivization structure that his group operates under. So it's really hard then to kind of swim upstream or kind of operate against a headwind like that for what you're being pushed into from the incentive side.
Yeah. Well, I think it's definitely something a lot of us are talking about in healthcare, and hopefully all fighting for change and improvement. So instead of it's an either you live your life totally in the hospital or you just don't really care. Like that's not reality in either one of those spectrums. It's somewhere along the spectrum, and we just hopefully got to push it in the best balance ultimately for patients. That leads to sustainable healthcare with a group of people, doctors that aren't exploited, but still able to deliver good care in a system that values us, which can be questioned, unfortunately, sometimes. But on that really happy note,
Yeah.
Woo. I mean, there's good things, right? I don't want to end on a total, bummer, but I do think that Graham and some of our previous guests really care deeply about this and are working for change. And I think we're seeing little progress here and there, but really appreciate his time and getting to talk to him. He is a medical celebrity indeed. So thank you for joining us on another episode of the podcast for Doctors by Doctors. See you next time.
Thanks for joining us this episode. You can catch the podcast For Doctors by Doctors on Apple, Spotify, YouTube, and all the major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. As always, thank you for listening. The next time you see a doctor, maybe you should prescribe this podcast. We'll see you next time.